Thank you, Dr. Abhishek. Thank you, Chandrasekhar and Renuka, for this invitation to be amongst you all. I was also part of ChanRe for quite some time, so I'm proud to be here. And the task given to me was ANA positive in a patient. What should I do? That was a question Chandrasekhar asked me to answer here. And since morning, I think I've been listening to ANA, and I myself listened to the pediatric rheumatologist talking about ANA. She stole my most of my what I wanted to tell, told my thunder, or should I say. So ANA is, as you all know, it's worth the repetition because it is one of the commonly asked question, commonly misinterpreted question, and a positive ANA test can evoke a lot of emotions in the patient and also in the doctor who has ordered it. So when a patient comes to me with a positive ANA report, we should have a practical way to answer them and give how much importance we should give to that test. So many of the slides I am going to show are already shown to you. It's a test which we all know that it is a test to detect antinuclear antibodies, and it is generally asked in practice to screen for autoimmune connective tissue disease. Sometimes it is also used as a screening test for single organ autoimmune diseases like autoimmune hepatitis, etc. And you have learned now that immunofluorescence is the method of choice. A positive test would generally lead to more testing. So that's a problem. When you ask for a test, generally it invites more tests because it is only a screening test. So these are the causes which you all know by now, like connective tissue diseases, including rheumatoid arthritis. 40% of the rheumatoids can have ANA positivity. So this is where a confusion can come, particularly a 25-year-old female coming to me with what looks like exactly rheumatoid arthritis. Her rheumatoid factor is positive. She may have early rheumatoid arthritis, or she may have early lupus or early connective tissue disease. Here further testing would help. An anti-CCP coming positive and ANA becoming negative would probably help me to bracket her into a rheumatoid category rather than a lupus category. If anti-CCP comes negative and ANA comes positive, then we may have to investigate her for lupus or other connective tissue diseases. So these are the few nuances, and if the same like somebody who comes to me with what looked like rheumatoid arthritis of 4 years duration with few deformities and a rheumatoid nodule, probably this confusion will not arise. In that scenario, a rheumatoid factor positive test, I may not even need an anti-CCP test to confirm that it is rheumatoid and treat. So we have to use our judgment before we request more and more tests. As I was alluding to earlier, some of the single organ autoimmune diseases where ANA is part of the investigation profile is autoimmune hepatitis, primary biliary cirrhosis, and sometimes autoimmune thyroid disease. We don't ask for ANA when we suspect autoimmune thyroid disease, but we have a patient who presents with relatively vague multi-organ like presentation, fever, weight loss. We were suspecting a little bit of lupus there. If ANA comes positive, all your ANA profiles and double-stranded DNA are negative, then do an anti-TPO sometimes, that can help us to pick up autoimmune thyroiditis, which can present with sometimes so-called within brackets autoimmune type of clinical picture, and sometimes even cause some kind of encephalitis pictures as well. Another area where we need ANA is juvenile idiopathic arthritis, and the exact indication was already alluded to the previous speakers. The problem is ANA can be positive in multiple clinical scenarios, and it can be positive depending upon the age of the patient. Anywhere between 10 to 35% of the patients can be normal, so-called normal patients can have ANA positivity. What does it mean is not clearly understood. Why people have a detectable autoantibodies, and some of the autoantibodies are present in almost everybody. See, if you look at rheumatoid factor, the lab says, say your ELISA cutoff is say 20, and anything above 20 is be considered positive. Higher the titer is more important. But still a lot of people can have 18. So people have now autoantibodies. They are not pathogenic many times. So what we are worried about is a pathogenic autoantibodies, and many viral infections like hepatitis B, COVID, Epstein-Barr virus, CMV, and even parvovirus can produce an ANA positivity. Tuberculosis and syphilis can do it. And many drugs, we should never forget drugs in our clinical practice. When somebody comes to with any symptoms, always think whether the drug which patient is taking can cause this. Somebody comes to you with young female, started on anti-epileptic, complaints of tiredness and ANA positive and hair fall. It looks like lupus. It could be the phenytoin or some drug which they have started can cause all these things as the potential symptom. So spectrum. So we need to always consider drugs in the differential diagnosis of our clinical illness which we are seeing on a day-to-day basis. And some of the drugs I have already written here, and many malignancies, particularly hematological malignancies, can have ANA positivity. And one of the things we might say, somebody comes to us with an ANA positivity, not so well patient. So somebody is pakka normal patient who has done it for as a part of a profile, like a lab does, okay, we'll check everything and we'll do a comprehensive arthritis profile. Probably we can ignore it. But a relatively sick looking patient coming with ANA positivity and doesn't seem to have any autoimmune connective tissue disease, sometimes it can be a manifestation or a paraneoplastic phenomena. So somewhere in the corner of our mind we should start thinking whether we should look for any malignancies. And the technology has been beautifully alluded to in the past, so I will not. The biggest advantage is now, earlier when we were training, we have to strain our eyes and look into the microscope and try to interpret. Now you just put it in, it comes in the big screen. You can even project it like this and see the pattern. So the life for the lab technician or the microbiologist or a pathologist who is interpreting has become little more easier. So there is a new movement to call this as anti-cell antibodies, I think, which has been alluded to. So, but the name is stuck. I don't think it's going to change in the near future. If somebody say anti-cell antibodies, and our clinicians are going to ask for anti-nuclear antibodies and anti-cell antibodies, and the lab will charge for both and give you the report, right? See, one example I will tell you. Anti-cardiolipin antibodies, anti-phospholipid antibodies. People do ask, I get reports for anti-phospholipid antibodies and anti-cardiolipin antibodies and no anti-beta-2-GP antibodies when you request for APLA. So if you tick both, lab will do it. I don't know what exactly is the difference. Many times I don't understand, but lab will do and you get reports. So you should know what we are looking for. So in future, maybe the youngsters here might use anti-cell antibody test rather than anti-nuclear antibody. For us, for the time being, anti-nuclear antibody stays, and we know that it is only not anti-nuclear antibody. It can also pick up antibodies against components which are there in the cytoplasm. So if you know that, that is enough. So these are few sample tests. So if I have a test in front of me, I will always look whether it is positive or negative, because many times people always look at the other side. There is some column reference positive. The patient will be negative. So a lot of patients have come because it was positive in the reference side. So always look at what is the patient's result. Positive, yes, and look at the pattern. The pattern sometimes helps us to point towards which other test we should do, and intensity is also useful. 1 plus, 2 plus, 3 plus, 4 plus intensity they give. The stronger the intensity, it may be more important. They may have more antibodies. And at the starting primary titration is this patient has only 1:100 positive, and it was not positive beyond that, and its intensity was poor. So there's a good chance that this patient may not have an autoimmune disease. And they have already started calling it as ANA/anticellular antibody. This is a report I picked up from the internet, some Brazilian report. their pattern is nuclear. The end titer is given here, 1:1280. So this is likely to be much more strongly associated with autoimmune connective tissue disease. So this small capsule here tells us that the patient has got 1:80 positive. The predictive value for CTD is only 2%. But somebody has a higher titer, 1:640, the predictive value can go up to 50%. So look at always the end titer, which will bigger the end titer, like 1:640 and above. That test may have a relevance and we should investigate them further. Again, this is another test. Here, look at the end titer is 1:320. And this, again, lot of people get confused with this. This is just a lab giving us an explanation what it means. But people do get confused with what's happening. I have so many antibodies like that. So always, this is what is important. The other page you can just, if you are interested, you can read. Otherwise, don't try to interpret. And these are few examples of patterns. And some of the slides are courtesy Dr. Abhishek Patel, who is here as the chairperson. And these are the patterns which I'll skip through. And this also was shown by Dr. Renuka. When we were training, the things were very simple. ANA, we used to interpret as well. There are only few patterns. You are either a rim pattern, a diffuse pattern, fine speckled, dark speckled, nucleolar, and centromere, and done. So there was never a confusion. Now so many patterns are available. Of course, cytoplasm pattern is important, but even as a rheumatologist, I find it difficult to interpret now. The labs and the clinician don't seem to talk to each other well, and some of the labs wants to look smart and give us a lot of information which a clinician cannot even interpret. Like if a ANA profile has got some 32, 42 items, one positive, PCNA, one plus positive, we don't know. I don't know how to interpret it, right? So we don't have enough experience to interpret it in a meaningful way. So we struggle with, as a specialist we struggle. I wonder if a non-specialist probably would thoroughly get confused. This slide we have already discussed. Just one small case, who had seen a male patient with knee pain and neck pain, some joint pains, no clinical arthritis. It looks like early osteoarthritis. He's a diabetic. The pain, nature of pain looked like diabetic neuropathic burning type of pain. So, but tests were done as a part of an arthritis profile. So he has an arthritis profile was ticked, and ANA is positive at 1:100. ANA profile also was done. Everything was negative except low intensity positive J1. And somebody has labeled him as dermatomyositis and started treating him with steroid and methotrexate. So here the probability of having lupus or CTD is very low because he's a male, older male, knee pain, no arthritis, and low titer positivity, and other explanation for the aches and pains. So low probability. So here the positives is a low, like a pretest probability scenario. And the best scenario would have been the test should not have been asked for. And if it is asked for, I think we have to reassure the patient that it is a low titer positivity is common in your age group. So we will ignore the test and will concentrate on what you have. In contrast to the other patient who is a young lady with all the many features to suggest lupus, similar to the case shown to you by our pediatrician. And here the pretest probability is high, and this patient would require ANA profile, double stranded DNA, complements, etc. So these are the connective tissue disease we generally look for. So the last sentence is important. If there is no compatible clinical phenotype, the default position by me or any clinician is that an isolated positive ANA is clinically insignificant, and stop the discussion and reassure the patient and ask them to come if they have any new symptoms which worries them. Again, this is a pretest probability curve. A patient, young woman with a hair fall and polyarthralgias with no arthritis. Her pretest probability is 1%, but if ANA immunofluorescent, even if it comes positive, a post-test probability only goes up to 6%. vis-a-vis a young woman with lot of features suggestive of lupus, like a rash, polyarthritis, proteinuria. Her pretest probability itself is more than 50%. By ANA immunofluorescence positive will bring it down to almost close to 90%. So the pretest probability, if it is high, your post-test probability for a connective tissue disease will be higher. And look at this list. The condition with almost 100%, I'll say almost 100% positivity for ANA, there is no lupus here. So ANA is always associated with lupus in at least popular perception, a general practitioner, physician, or even public. ANA is lupus. So, but the conditions which have almost positive lupus, 100% positivity for ANS, ANA is MCTD, autoimmune hepatitis, primary biliary cirrhosis, and drug-induced lupus. So even lupus is about 90-95%. So ANA testing is a screening tool, not useful to monitor the disease activity. Negative ANA almost always, not always, almost rules out lupus. If you still strongly suspect lupus, I think this patient needs to be referred to a rheumatologist, because ANA negative lupus does occur, but there are many other possibilities like combined variable immunodeficiency, the lupus-like presentation, no antibodies, more likely to be CVID or some other diseases. And sensitivity and specificity also depends on the clinical settings. I will allude it to in the next slide. It's a screening tool, not a diagnostic or prognostic tool. When there is no indication for ANA, always avoid doing an ANA. So this is the most important point. If you do it, then we'll end up with having a paper which you have to deal with. A patient who become anxious, whom you have to deal with. Sometimes you may have to refer them to a rheumatologist. They may have to wait for 3 months to see us and pay some 1,000 rupees. So if they come to me, then I cannot send them without doing more tests. Right? Then we'll say, Dr. Dharmanand, I sent a patient, he missed a lupus. So I don't want that to happen. So I will do more tests. So the best scenario is to, if there is no clinical suspicion of CTD, don't do it. And having said that, I don't know, is there any false positive ANA? If ANA somebody has positive in significant amount of titer, low titer transient positivity I would ignore. Post-COVID somebody has a positive, ignore. Absolutely all right, 1:640 positive, clinically absolutely no lupus, no nothing positive. What will happen to this patient? I don't know. This we may be having a patient who has a preclinical autoimmunity. So there may be a paraneoplastic phenomena. They may develop a breast cancer in the near future. So these are the patients. They can be under follow-up. Future is difficult to predict, and whatever we can do, whatever is known in the literature to reduce the chance of preclinical autoimmunity from becoming a clinical autoimmunity, like stopping smoking and lifestyle changes, dietary changes, can be advised to these patients. And I was talking about the pretest probability and the interpretation of testing in the clinical setting. When the test came up in the 50s, most of the ANA tests came from a rheumatology immunology units. So they have high pretest probability for these CTDs. Then over time, more internal medicines, nephrologists, gastroenterologists started requesting, correctly, not that they should not request, because there are many diseases are known to be associated with it, and physicians always are confronted with multi-system presentation, PUOs, etc. But the pretest probability will be lower, and so the chance that the test results will lead to a diagnosis of CTD becomes lower and lower. Now, almost everybody asks, including the patient themselves. So patients go and say, I have 5,000 rupees, do all the tests. Like this kind of a scenario, so pretest probability becomes very low, so post-test probability becomes less. So which setting? If a test is coming from a rheumatology unit, it has got a higher sensitivity and specificity. Maybe from the patient or a lab part of the profiles or part of general health checkup, then chance that this will have a sensitivity, specificity will be very low. So we have to interpret the sensitivity, specificity also in the context of from where the tests are coming from. And these are the few indications I think we all know by now, so I will skip this. So if it comes positive and the patient looks like has a CTD and has got a good pretest probability of CTD, then I would do directed investigations. Probably most of us will do an ANA profile, double stranded DNA by ELISA, because the double stranded DNA by ANA profile, whatever the immunoblot assay can miss double stranded DNA, we'll do a complement, blood counts, look for counts and other clues for CTD, ESR and CRP. This we will do. Then depending upon what is my suspicion, if my suspicion is lupus, then renal function, urine analysis becomes more important. If I am suspecting a myositis, I will do a muscle enzymes. I will also look at my liver function test and see SGOT, GPT is high or not. They are also muscle enzymes. And the appropriate imaging and biopsy, depending if somebody with a salivary gland recurrent swelling, we may require a minor salivary gland biopsy. Or if somebody with the proteinuria will go for a renal biopsy. So this is a immunoblot assay, which I will skip. So last but one slide. The lab tests are meant for sick people, not for worried well. So this is worried well who are people with some vague illness, relatives of patients with CTD. So we can always interpret the lab results much more efficiently when it is done for sick people. When it is done by worried well, it becomes much more difficult to interpret and difficult to manage. So we had, I have tried to bring in a little bit of clarity, and I'm sure all the speakers from Ashish to Chandrasekhar and I forget her name, sorry, Sushma, and all the speakers, Renuka, have tried to bring in a little bit of clarity to how to interpret this beautiful test, but a difficult test to interpret. I think I've added a little bit to the clarity today. Thank you very much for patience.